to share with you guys some of the results that we've generated recently as part of some work that we were doing that was funded through the Healthy Seniors Pilot Project funding from Public Health Agency of Canada. And one of those projects that I was involved in is specifically aiming to examine dementia and dementia risk with the aim of preventing dementia in early stages. And so as part of this work, we had a large team of researchers at NB-IRDT, but also within other departments at UNB, Chris McGibbon and Andrew Sexton, as well as partners at the regional health authorities, Dr. Pamela Jarrett and Carla Fagg. So this work was really a collaborative effort. I'm just going to make this smaller so it's easier for me to see. So just as a bit of a background to this presentation, the prevalence of dementia will increase because our population are increasing, increasing in terms of the aging populations, individuals in older ages. And so the number of older adults living with dementia is just by that sheer number of increasing that bracket of the age population are expected to triple by the year 2050. So the projections are quite dire because caring for individuals with dementia requires substantial resources, individual, family level resources, as well as system level resources, due to the need to provide home care, as well as other specialized medical services to individuals who are living with dementia. And so we really need to make a society-wide attention to the prevention of this disease, because there's a lot of important evidence to demonstrate that prevention is feasible and that prevention is possible. And so a real focus on this piece is important, because thinking later on in the trajectory of dementia is much more expensive. So the prevention piece is really where we're going to be able to make that change so that we can manage the onset of dementia in later life, the quantity. And so leading researchers interestingly suggest that about a third of cases could be prevented. And then these risk factors are really in mid to late life and are really common to other chronic diseases. So interestingly, if we're aiming to prevent dementia, we're also inadvertently aiming to reduce risk of other important chronic conditions. So these things share similar risk factors and similar etiologies. So as part of this work, we also defined what is the distribution of dementia across the province using the Canadian chronic disease surveillance system data. And so these data search billing records for hospitalizations and physician services to capture individuals that have been coded as having dementia. And so when individuals meet the case definition, we identify them as being a case of dementia in the province. And what we did was we characterized the rates of dementia over time. And in these figures here, just shown the estimates where we pooled them over 5-year periods from 2004 to 2018. And probably as we thought when we saw this first, we thought, wow, that's a big striking difference between that first period and then subsequent periods. And so thinking that this is unlikely to be a true effect of increasing in the disease incidence and prevalence, it really relates to the data that we have available to capture this information. And billing data in the early 2000s was less likely to capture individuals with dementia because there weren't necessarily good opportunities for dementia diagnoses. That's improved substantially over time, but also that oftentimes dementia was not diagnosed because in this earlier period, the availability of dementia drugs was not in the formulary, so those were not captured as diseases in the claims data. And so for a variety of reasons, we really think that this increase is reflective of methodological issues with the data, but more recently, this seems to be leveling off in terms of the estimates, and the distribution of dementia in New Brunswick is quite similar with respect to other provinces in Canada. We were also interested in this work to characterize the distribution across the province of the incidence and prevalence, and these are the 7 health regions or health zones across the province, and just representing a difference across the regions, although the estimates are quite similar with respect to the number of dementia people, individuals in each of these regions. And this is data for the most recent time period. And so, as I mentioned, this was all part of a larger study that included many different components that were aiming to focus in on brain health in populations that were at risk of dementia. So 3 objectives. The objective I'm going to talk to you about today is that this third objective was really focusing in on the evaluation and the monitoring piece, but it was nested with, this objective was nested within these other 2 that were really aiming to understand how older adults want to be engaged for brain health related research and brain health related information, and then a number of interventions aiming to actually modify the risk of dementia at the individual level, so active randomized controlled trial types of studies. And then the work that I'm going to talk about to you today is aiming to support really those first 2 objectives as we move beyond this initial study into subsequent work. So the objectives of this third part of the work were really aiming to support the scaling and the sustainability planning for brain health interventions that were evaluated in this study, but also more generally. So the idea of understanding where our risk factors more common allows us to know where maybe these interventions are most needed and our resources may be best directed. So identifying interventions that are effective at reducing risk, we can then apply them in areas that may have the greatest burden. We're also really interested in understanding what is that burden of dementia, what risk factors are more prevalent, and which ones do we while acting on may have a greater impact. And in understanding the distribution of these dementia risk factors is also really interesting to understand how these are changing over time. We see that our population behavioral factors are changing with respect to also other conditions like diabetes and high rates of hypertension, which are all related to dementia as well. And so trying to understand how these risk factors are changing over time also helps us to understand how interventions may be modifying those risk factors, so evaluating the impact of population-based interventions, but also to understand how in addition to the aging population, changes in behavioral risk factors may relate to changes in expected or forecasted numbers of dementia cases in the future. So for this work, we used existing data, which is extremely valuable available from Statistics Canada, because it gives us information over a long period of time with quite a large number of individuals. The Canadian Community Health Survey, or CCHS, as I'll refer to it throughout this presentation, started data collection in 2000, and the most recent year that was available when we were doing the analyses was 2020. And so we used all those years of data, we pooled them into 5-year time periods, and so which gave us a much larger sample within each of those time periods for New Brunswick. The study is across Canada and New Brunswick is a subsample within that. We also use the census data from the 4 census that straddled those time periods to give us information about what the population structure was in each area of New Brunswick that we derived a prevalence estimate for. And so the areas that we derived prevalence estimates for were census subdivisions. So in 2016, there was about 242 of them. So for each of these areas, we defined how much, so the percentage of the individuals living in that area that engaged in any of these risky behaviors. The risk factors that we defined were defined for midlife and late life. So midlife being people between the ages of 45 and 64, and then late life being for individuals over the age of 65. And so the literature suggests that certain risk factors are midlife risk factors and others are late life. And this is where we pulled these from. And so the midlife risk factors that we were able to examine using these data were heavy drinking, obesity, and hypertension. And the late life risk factors that we were able to examine include smoking, inactivity, social isolation, and diabetes. So there's other risk factors as well that we had hoped to examine that were not available in these data sets. And so next steps for us are also adding those as part of this work. But these 8 is what we've focused on so far. So this is the definition of the risk factors. Again, these are survey data taken from Statistics Canada, Canadian Community Health Survey. So heavy drinking as a midlife risk factor, and we used questions from the survey that asked people a frequency of their drinking, and drinking 4 to 6 times per week or every day was how we defined heavy drinking. Obesity was a current BMI of greater than 30. Hypertension was determined if someone had mentioned they had been diagnosed by a clinician with high blood pressure. And the late life risk factors included smoking, and we characterized whether individuals were currently smoking. Physical activity was derived using a question about their physical activity. And so categories that represented individuals who were self-reported as sedentary or inactive on a weekly basis were what we characterized as physically inactive. Social isolation, we used 2 approaches to defining it in the data. Single, never married, marital status is one variable that's often used in the dementia risk factor literature. But in addition to that, we also characterized a variable that captures a sense of belonging in one's community. And we defined somewhat or a very weak sense of belonging as being the risk factor for that. So we have 2 variables related to social isolation. And then diabetes was defined as someone saying that they had a clinician diagnosed with type 1 or type 2 diabetes. So these risk factor data were used to derive small areas. So we had the 242 areas in New Brunswick or census subdivisions. And these represent municipalities or parishes. So, a variable number of individuals, but, areas that people tend to congregate within. So thinking about Fredericton, for example, and we estimated the prevalence for each of the risk factors I just shared with you in the previous slide for these 4 time points, 5-year periods. We developed prediction models for each of the risk factors, considering demographic, socioeconomic, and area level characteristics using the CCHS data. And then we used post-stratification using census data for each of the census that aligned with each of those 5-year periods to estimate or predict the estimate for that specific area. And then using some really fancy spatial-temporal models, we were able to adjust for the spatial correlation between communities. Communities that are more close together are likely to be more similar than communities that are further apart. And so this approach just helps us to really increase the robustness of the prevalence estimates that we were deriving. So we estimated the prevalence of each of the risk factors, but then in order to get a combined sense of which areas of the province might be most vulnerable to dementia, we combined all the risk factor information that we had derived for each individual risk factor into one score. So there were 8 risk factors that we defined. And so what we call the Dementia Vulnerability Index for communities, or the DVIC, was a summary measure that captured information about all the 8 risk factors. And so it provides an opportunity to identify which communities are at increased vulnerability of dementia. So those with higher scores mean that they are a community that is ranked among the highest of all communities for the greater number of risk factors. So we ranked a community as high in a risk factor if they were in the top 20% of all of all communities. And it could range from 0 to 8, but nobody in our results had an 8. But those with higher scores are really indicative of having a higher burden of dementia risk factors. And so then digging in to understand what risk factors are at greatest burden in these communities that are driving this score then helps us to understand where we may be able to direct resources or types of programs to help mitigate that risk. All right, so just getting into the results. And before I do, just have a couple notes here. So the data that we are presenting is for communities, the 242 communities that I had mentioned previously, but we've grouped them into health zones. So a lot of administration and programs are delivered at the health zone level, of course, other areas within there too, but we have presented them at the health zone level. And the x-axis, there's a bunch of graphs that I'm going to show you. The x-axis changes just because of the scale of the slide, just to make things where they can be easier to see. So just so you're aware that that's not consistent across all the results slides. All right, so what does this look like? So just to orient you, each of these dots is a community in New Brunswick, so one of those 440 some odd communities. And then we have each of the health zones, so 1 through 7, 1 being Moncton, St. John, Fredericton, Edmundston, Campbellton. Oh no, I messed this. Oh yes, I didn't mess this up. Edmundston, Campbellton, Bathurst, and then Miramichi. And so this is the estimate, so the percentage of the community, and these are midlife risk factors, so the percentage of the community who are between the ages of 45 and 64 who are defined as being obese, for example, in this first column here. So the midlife risk factors were obesity, heavy drinking, and hypertension. So what we see is the prevalence of obesity and hypertension were similar. The prevalence of heavy drinking is lower than the other two, and we do see heterogeneity across the communities. So we have communities that have higher levels, and then communities that we observe as having lower levels for some of these risk factors. So these are the communities with less obesity, for example. So this is the same data that was on the previous slide, but this is using another statistical approach, which is called a box and whisker plot. Its real intention is to understand what are outliers in the data that we're looking at. And so we can see that these dots, which represent outlying communities, so they're kind of different from the rest of the communities in that health zone. And so they can really help us to identify maybe areas that we want to, target interventions for obesity, or for prevention of hypertension, for example, and the same here for heavy drinking. So we do certainly see substantial overlap in the distribution of the risk factors across health zones, but we have more outliers identified for communities with higher prevalence, so more communities that don't fit like the rest on the high end, so the bad end, than on the lower end. So it's not really seeing as many outliers that are better than the rest, but it's on that other end. And we do see quite a number of outliers for heavy drinking. Obviously, the rates are much lower and much more precise given their range, but we definitely see some more outlying communities with respect to this risk factor. So now looking at late life risk factors, so late life is over the age of 64. So we looked at diabetes, physical inactivity, smoking, and then 2 measures of social isolation, lack of community belonging, and then single marital status. And so again, these are a dot for each community. So prevalence of physical activity was substantially higher than the prevalence of any of the other risk factors. And so that was really important because for us, especially because the intervention that was part of this larger study was aiming to increase physical activity, and as one of the interventions that has been demonstrated to be very effective of reducing one's risk of dementia. We also saw that prevalence of diabetes, smoking, and social isolation were in similar ranges, with some important outliers, especially for smoking. And that single marital status was among the rarest of the risk factors examined. Again, same exact data as the previous slide, just the box whisker plot look to identify what are those outlying communities. So again, we have substantial overlap in the distribution of the risk factors across or within health zones, but we do identify more outliers for communities with higher prevalence in most of the risk factors, except for physical inactivity. So with respect to physical inactivity, we see that older adults in some communities are much less likely to be physically inactive than other communities. And so this was interesting to see because it's contrary to what we've seen for the rest of the risk factors, where we tend to see communities that are doing more poorly. So in this case, it's interesting to think about, well, why are they more physically active? Are there characteristics of these communities that we can learn from in terms of their better behavior with respect to dementia risk, than thinking about these other risk factors and then trying to understand why they're higher in burden in these communities. So we see quite a number of outliers for diabetes and for smoking as a risk factor as well. So that the data that I presented to you here was for the 2016 year, so the most recent 5 years, but we also derived these for those 4-year time or 5-year time periods over the last 20 years. So this allows us to see how the distribution of these risk factors have changed over time. And what we do see in many of these risk factors is that there's, slight increases as time goes on. So the prevalence is higher in 2016 than it was in 2001. And we also see a shift in outliers from lower to higher prevalence. So we are seeing much more outliers on the higher end than we did on the lower end in the earlier years. And then for some risk factors, we don't even have any outliers on the lower end in the more recent year, for example. So the distribution of these risk factors is changing slightly over time. We're also seeing more variability and more outliers over time. So heavy drinking and smoking are becoming more variable, and more communities with higher prevalence are outliers, is what we're observing with these two specific risk factors. Oops, okay. For physical inactivity, we're seeing less outliers, and the outliers that we were seeing in earlier years are communities that are more physically active, whereas in more recent years, we're seeing that communities are becoming more similar to one another, and so the distribution of them is suggesting that there's less communities that are on the better end or more physically active than others. So trying to identify problematic communities for this risk factor, it is a little bit more difficult, and the strategy might be not effective for physical inactivity, at least. And so when we combine the risk factors, we are aiming to identify communities that have high scores, meaning that they're scoring high on many of the risk factors, and how many depends on what their score is. So a maximum score was 8. We didn't get any community that was highest in all of the risk factors, but we did get some communities that had a maximum score of 6. So 6 of the risk factors that community was ranked within the top 20%. We see substantial overlap in the distribution of this measure or this index across health zones, but we do see that some health zones have higher values. So trying to maybe think about what those communities are high in terms of the risk factors will help us to target interventions that might be specifically needed in those communities. The number of communities with high scores is increasing over time slightly. We have more communities with scores of 5 and 6 than we did in the earliest time period. And health zones 3, 5, 6 had highest scores in the most recent years. So digging deeper into who are those communities, where are they in the province and within that health zone, and then what are some of those characteristics about the risk factors, and then trying to understand what those communities' needs are, as well as more generally. So just providing an overview of what we found. So really an important, I think, outcome of this work was really to identify that we can use existing data. So these are all data that have been collected over time and are available for research use. So they can be leveraged to inform on the burden of dementia risk at the community level, which is important for the work we're doing because we're aiming to move on to next steps of the intervention, and understanding where that burden might be greatest helps us to direct those resources. So these outlying communities might be those that we suggest are most vulnerable to dementia, and might be where we want to go next with the interventions that we identify as being effective. So physical inactivity was the most prevalent risk factor, had the most outliers and with the lowest prevalence. And outliers for other risk factors were more common on the higher end of the distribution for the communities. So we do see a slight increase in prevalence of these risk factors over time, a lot more variability, so suggesting that communities are less like one another, and we're seeing more outliers on the bad end for most of the health regions that we examined. So this possibly suggests that future prevalence of dementia may be greater than we expect using current projections with only considering age alone. So no community has ranked in the top for all 8 risk factors, but a number of communities did have higher scores that were increased over time. So suggesting that there's more burden in specific areas of the province with respect to dementia risk. So just some strengths and limitations of this research. Strengths, we use population-based data sources, so that's Statistics Canada, Canadian Community Health Survey. We use complex statistical modeling to provide estimates of prevalence for each of these risk factors. We focus on modifiable risk factors. There are other risk factors for dementia that aren't necessarily modifiable in mid and late life, which is the area of focus for this. But for example, education is one of those risk factors that is modifiable, but at the earlier end age. But we focused our work on the modifiable risk factors in the age period that was relevant for the larger study. And another strength is that we estimated prevalence in that at-risk population, so people in their midlife, and then different risk factors for people in their late life. And we did this for small communities, which help us to understand where the need is greatest to be able to direct resources in a much more targeted way. Of course, always with research, we have limitations, and important to acknowledge those, that these are, of course, model-based estimates derived from survey data. So they provide us with a guess of what the prevalence estimate is in that community. And the data that we are using to derive these estimates are based on self-reported behavioral data. So there's obvious limitations with respect to those types of data, and that we weren't also able to examine all risk factors with the data available from Statistics Canada, Canadian Community Health Survey. So we're exploring other types of data sources that'll allow us to do that. So what are our next steps for this work? We're really interested in deriving prevalence estimates for the additional dementia risk factors, and we're just applying for some funding right now to be able to wrap this up. So these include depression, air pollution, traumatic brain injury, among a few others as well. We really want to understand this index better that we've created to understand how it relates to cases of dementia in communities across New Brunswick. So that's some of the work that we'll be doing as well. And because the data that we use is not specific to New Brunswick, it's collected across Canada. The project we did was specific to New Brunswick because it was an HSBP project, but we can derive these same estimates across Canada. So for other jurisdictions at the national level, and then derive this index that we've created as well for communities across Canada. And of course, another big part of all our research is to disseminate our research findings, to further develop our research with relevant stakeholders like all of yourselves here today. So before we sort of wrap up for questions, I just need to, of course, acknowledge all our partners and our funding partners, especially with which this work would not be possible. So Healthy Seniors Pilot Project funding through social development is really paramount to this work, as well as the MSSU, because they are primary funders of NB-IRDT, and funding for MSSU comes from the Canadian Institute for Health Research, Research New Brunswick, through the government of New Brunswick as well. So thank you all so much for taking the time to listen to my presentation.